Racial Disparities in Lyme Disease, presented by Melissa Wright and Dr. Elizabeth Maloney. Hello, my name is Melissa Wright, and I am the Director of Patient Engagement and Outreach for LymeDisease.org. I also serve as the Project Manager for our patient registry, My Lyme Data. I've been advocating for patients with Lyme disease for the last 7.5 years, including government testimony and panel moderation, and I am excited to share this important talk with you today.
Hello, I'm Dr. Betty Maloney, Education Co-Director for Invisible International. My focus is on healthcare policy and clinician education related to tick-borne diseases. I've published in peer-reviewed journals, advised government and non-government agencies, and I was a member of the Federal Advisory Committee, the Tick-Borne Disease Working Group. Thank you and welcome.
Here is our agenda. We will present 2 patient cases involving a person of color, discuss the meaning of health equity and health disparity, cover the current CDC reporting for both probable and confirmed Lyme cases, and discuss how we may begin to eliminate health disparities in Lyme disease for people of color. The learning objectives for today's course are listed here. Dr. Maloney and I have no financial conflicts to disclose.
We begin our presentation with 2 cases for you to consider. The first is a 34-year-old Hispanic gentleman from Wisconsin, a Lyme endemic state. He presents in June with a 1-week history of fatigue, myalgias, and a new skin lesion. The lesion is expanding, but not painful or pruritic. He's had no known tick bites. He owns and works at a landscaping company. On exam, he appears tired. Aside from the single skin finding, his exam is otherwise unremarkable. Here's a picture of his skin lesion on the lateral aspect of the knee. It is generally dark brown in color and oval shaped. It is not warm or tender to the touch. It was decided that his symptoms and skin findings were job related. The fatigue and myalgias were from long hours on the job, and the skin lesion was thought to be a bruise. The second case involves a 52-year-old Black woman from Maryland. She presents in late May with a 5-day history of fever, stiff neck, headache, and arthralgias. Although she had a known untreated tick bite 2 weeks earlier, she had no apparent erythema migrans rash. On exam, she had a temperature of 100 degrees and a slightly stiff neck. She was diagnosed with a viral syndrome and symptomatic care was recommended. She returned 2 weeks later with an obvious facial nerve palsy. 2-tier testing was positive for Lyme disease. These 2 cases share some common factors. Both involved patients of color, and both were initially misdiagnosed despite having Lyme-compatible histories. The gentleman in case 1 had symptoms of early Lyme disease and a new skin lesion, which in light of his other symptoms was likely an EM rash, but misdiagnosed as a bruise. The woman in case 2 had a recent tick bite in a Lyme endemic area that went untreated. When she presented with classic symptoms of early Lyme disease without an apparent erythema migrans rash, she was misdiagnosed with a viral syndrome. These cases raise this question. Do these cases represent isolated misfortunes, or is it a more generalized failure of clinicians to recognize Lyme disease in people of color?
Conversation of racial disparities. When discussing racial disparities as they relate to Lyme, we will briefly overview health inequity based on race or ethnicity, CDC statistical reporting for confirmed and probable cases of Lyme, and how disparities may be eliminated. To help stage our conversation, we first need to define our key terms: health equity and health disparity. According to the CDC, health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health, while health disparity is preventable differences in the burden of disease or opportunity to achieve optimal health. Here I am offering two illustrations that may help us visually understand what health equity and health disparity look like. To the left, we can see here equity is providing the resources needed to ensure everyone has a fair opportunity. And to the right, an image of the water plant in Flint, Michigan, which represents a horrific example of a disparity at play, where safe drinking water remains a health crisis for the people of that community. So what causes health inequities for people of color? I like to offer this quote from a Health Affairs article on racism and health. This will help to frame the examples I provide next. Racism is not always conscious, explicit, or readily visible. Often it is systemic and structural. Systemic and structural forms of racism are pervasively and deeply embedded in systems, laws, written or unwritten policies, and entrenched practices and beliefs that produce, condone, and perpetuate widespread unfair treatment and oppression of people of color with adverse health consequences. Let me give you an example from the recent COVID-19 pandemic. Pulse oximetry, which as you know is used to measure oxygen saturation. The pulse oximeter has a known flaw that was seemingly overlooked in the face of the pandemic. Its readings yielded falsely elevated levels for patients with darker or more melanated skin. This is important to note because pulse oximeter readings were widely used to guide triage or treatment decisions for COVID-19. Studies have since revealed that this inherent flaw was associated with significantly delayed eligibility for COVID-19 therapies among Black and Hispanic patients, which may have contributed to worse outcomes among this patient population. Factors contributing to health inequities for people of color. Segregation, which dates back to the early 1900s in the United States, where services were deemed for colored or for whites only, which ultimately impacts exposure to education, snowballing into employment, income, and housing. Redlining, the practice of refusing to insure mortgages in Black neighborhoods, while incentivizing builders to build communities that would not be sold to Black families. This practice led to a lack of investment in and around Black neighborhoods, which impacted access to resources, including healthcare. Voter suppression, which may be self-explanatory, but being unable to vote to enact change in your immediate environment directly affects your quality of life and pursuit of health, and not to mention that those suppressed are disproportionately at risk of suffering from health disparities, according to the NIH. Medical mistrust, which exists in the Black community following a history of mistreatment and experimentation. As you can see, the issue is complex and nuanced and has ultimately impacted social determinants of health, education, wealth, and access to healthcare. Health disparities in Lyme disease. According to last year's Tick-Borne Disease Working Group report to Congress, whites are shown to have higher diagnosis rates of EM rashes compared to their Black counterparts, and Blacks presented with a higher incidence of Lyme arthritis. Similarly, Hispanics were less likely to present with an EM rash. So why does it matter what stage you are diagnosed at? Delayed diagnosis is associated with poorer outcomes, which is evidence of a health disparity for people of color. The data I will share from CDC reporting on confirmed and probable cases of Lyme may be a contributing factor to the notion that people of color have a relatively lower risk of Lyme disease than their white counterparts. CDC reporting. Let's consider how people of color are represented in Lyme disease CDC surveillance statistics. The CDC collects Lyme data on race and ethnicity, and when compared against census population statistics, it suggests a significant undercounting of people of color may be happening. The table here is compiled with data from a report on race, white, Black, Asian, and other, and combined data from a report on ethnicity to include the Hispanic and Latino information. In both instances, the proportion of people of color included in surveillance reports is diminutive compared to the Lyme case numbers for white or Caucasian categories. While combining information from two reports gives us a better understanding of the problem, the Hispanic percentage is not precise because that category may be double counted in the white population. You will notice that only 10% of the CDC confirmed and probable Lyme cases reported are from a minority population, despite non-whites making up over 40% of the US population. The surveillance data gives the false impression that people of color are at a lower risk of contracting Lyme disease than other populations. Additionally, the high risk of exposure of Hispanics is not reflected in the CDC surveillance numbers. The CDC identifies many reasons the surveillance numbers may underreport the true incidence among Hispanics, including inadequate healthcare access, language barriers, and lack of Lyme disease awareness, could cause both underdiagnosis and delays in diagnosis in the Hispanic population.
Given the known health disparities in Lyme disease, what can be done to eliminate them? Addressing structural health inequities will take a long and concerted effort. However, improving clinician education regarding Lyme disease in people of color is an important and achievable first step. Historically, classroom lectures and textbooks depicted EM rashes on light skin tones. Using materials that depict EMs on a variety of dark skin tones should reduce misdiagnoses of this hallmark finding of early Lyme disease, as that's what happened in case number 1. Classroom instruction that explicitly tackles biases and assumptions regarding the risk of Lyme disease in people of color should help future clinicians keep Lyme on their diagnostic radar for all patients, including the Black woman in case number 2.
In summary, racial disparities in Lyme disease are well documented. The root causes include systemic and structural barriers such as racial segregation, redlining, voter suppression, and medical mistrust. Improving clinician education regarding the risk of Lyme disease in people of color and its presentation in this patient population is a necessary and immediate first step towards reducing these disparities. Thank you.